It's about a very important topic, that is kidney stones. So the kidney stones typically present with the acute severe colicky flank pain that may radiate to groin. It is associated with the nausea and vomiting. Patients are unable to get comfortable and shifting position frequently as opposed with the peritonitis who lie still. So the diagnosis. So urine analysis may show the gross or microscopic hematuria in the 85% cases of the kidney stones. So gold standard investigation is a non-contrast abdominal CT scan. So ultrasound is preferred in the pregnant patient and in the children. Plain X-ray of the abdomen are still useful following the progression of the treatment of the larger stones. So larger stone progression or treatment are typically checked by the plain X-ray of the abdomen, and that stones are typically radio opaque. So radio opaque stones mean they are visible on X-rays. So some stones like uric acid stones are radiolucent. So these are radiolucent stones. So it means that are not visible on X-ray. So calcium stones typically divide into the two types. So calcium oxalate stones and the calcium phosphate stones. So calcium oxalate stone are the most common type of the stone. So it is the most common. So the shape of the calcium oxalates envelop are dumbbell shape. They are radio opaque, mean they are visible on the X-ray. So most common cause are idiopathic hypercalciuria, fat malabsorption. The fat malabsorption means Crohn disease or bowel resection. So bowel resection. So why this thing is a fat malabsorption is important because the retained fat in the intestinal lumen. So this fat may combine with the calcium and decrease calcium available to bind with oxalate. So it will lead to increase oxalate absorption and the intestine. Ethylene, in this way, it will lead to increased kidney stones. So ethylene glycol, that is antifreeze and hypervitaminosis, that is a toxicity of the vitamin C, may also lead to calcium oxalate stain. The calcium phosphate stones are wedge-shaped, prism-shaped stones. Most common cause, again, the idiopathic hypercalciuria, primary hyperthyroidism, and immobility syndromes. So the treatment of the calcium stones, so the hydration that lead to more than 2 liter of urine per day, that is a typically thiazide. So they decrease urinary calcium, right? Sometimes they ask they increase calcium reabsorption and decrease urinary calcium. So thiazide, again, a very important. Alpha blockers, the stone size is less than 10 millimeter and more than 5 millimeters. So alpha blocker are very important if the size of stone in between 10 millimeter of the mercury and in between 5 millimeter and 10 millimeter. Analgesia, so morphine, that is opioid, and NSAIDs, non-steroid anti-inflammatory drug. Typically, the ketorolac is a very important ketorolac. So strain of the urine. So filter the urine. So alkalinization of the urine is important for the oxalate stones, while the acidification of the urine is important for the calcium phosphate stones. So dietary modification of for the calcium stones. So the limited sodium. So what did limited sodium intake do? So decrease sodium, it will lead to decrease sodium. It will lead to increase sodium and water reabsorption. So increase the sodium and water reabsorption lead to the passive calcium reabsorption, right? So it in this way it will lead to decreased urinary calcium. So normal calcium intake is a very important. So calcium bind with oxalates, and in this way it inhibit oxalate absorption in intestine. Okay, so the potassium rich diets, so typically fruits and vegetables. So potassium rich diet, they increase urine citrate. So increase urine citrate, what it will do, increase urine citrate, it will form a soluble complex with the calcium. And in this way, the stones are. So decrease protein intake. So decrease protein intake is a very important because normally what does do? So protein normally increase urine calcium as well as decrease urine citrate. So protein increase the urine calcium and decrease urine citrate. In this way, it will increase the risk of the calcium stones. So decrease intake of the oxalate rich food. So this is some um, algorithm for the kidney stones. So the pregnant patient, if yes, do ultrasound. If not, CT, scan of the abdomen and the pelvis. That is non-contrast. The size is very important. If the size is less than 10 millimeter, we will go toward the medical management. If the size is more than 10 millimeter, so it's a surgical intervention needed. So surgical intervention or urological intervention typically needed of the size is more than 10 millimeter of the mercury. 10 millimeter, sorry, 10 millimeter. It's not a mercury. So if less than 20 millimeter, shock wave lithotropsy or ureteroscopy. If more than 20 millimeter, then percutaneous nephrolithotomy. So medical management, we already know about the alpha blocker when it is used, calcium channel blocker, analgesia, and the hydration. So uric acid stones, the next stone are uric acid stones. So these are some risk factor of the uric acid stone, that is a low urine pH, chronic diarrhea. So the chronic diarrhea also increase the urine pH because the in diarrhea we lost bicarbonate. So metabolic syndrome and diabetes mellitus. So some of the increased uric acid excretion. So gout and myeloproliferative disorders may lead to the increased uric acid excretion and increase urine concentration. So it will concentrate it in urine concentrated in the hot condition, arid climates, and dehydration. So low urine pH promote the formation of the uric acid stone. That is a very important, low urine pH. So the characteristic of the uric acid stone, they are radiolucent, mean they are not visible on the X-ray, diamond and the rhomboid shape, and the urine pH less than 5.5, very high yields. So less than 5.5, the urine pH in case of the uric acid stone, because this acidic environment promote the uric acid stone formation. So treatment of the uric acid stones are hydration, very important, alkalization, so increase the urinary pH, so it will inhibit the formation of the uric acid stones. So decrease uric acid production. So how will you decrease? So decrease the purine rich diets. One thing, decrease the diet that is rich in uric acids. So and allopurinols. So allopurinol decrease the uric acid production. That is a very important. That is a xanthine oxidase inhibitor, exo inhibitor. That is xanthine oxidase inhibitor. That is used for if the symptom are reoccurs, right? So recurrent uric acid stones, we give allopurinol, while other drugs that are uricosuric agents are not encouraged because they increase the risk of the uric acid stones. So struvite, magnesium ammonium phosphate stones. So they are ureas. They are caused by the urease producing organism that typically Klebsiella and Proteus. So what will they convert the urea into the ammonia. So it will lead to the increased urine pH. So increase urine pH, while the uric acid stone decrease urine pH, while the magnesium ammonium phosphate, that also known as struvite, are promoted by the increased urine pH. That is a very important for the struvite stone, increase urine pH, and uric acid stone decrease urine pH. So the clinical feature of the struvite stones, so the recurrent upper urinary tract infection, so fever, dysuria, and mild flank pain more common than the renal colic pain. So urine pH more than 8. So coffin-lid shaped crystal, while in case of the uric acid stone, the urine pH less than 5.5. Large staghorn calculi. So the treatment of the struvite stones are antibiotics. So antibiotic do not eliminate the source of infection because the bacteria grow within the stone. So that why percutaneous nephrolithotomy is usually required to remove the stone and urease inhibitors in selective patients. So cystine stones. So cystine spores are basically the defect in the nephrons that reabsorb that four amino acid, that are the cystine, ornithine, lysine, and arginine. So it will lead to the cystinuria. So that cystinuria is detected by the cyanide nitroprusside test. That will be the diagnostic for cystine stone. So what is the likely diagnosis in the patient with the intermittent flank pain, low volume void, and occasionally opposite the high volume of the void? So high volume. So that is a typically obstructive uropathy. So obstructive uropathy, right? So obstructive uropathy is a diagnosis. So it will lead to hypokalemia, that will lead to the weakness plus dehydration. So last important thing in the kidney stones in children typically present painless hematuria, painless hematuria.